So morning, everyone. Welcome to today's webinar on our insights from the Director of Public Health Annual Report for 2023-24. My name is Alex Quarry-Jones. I'm a Senior Programme Officer in the governance team here at Birmingham Public Health. And my colleague, Avneet, do you actually want to introduce yourself? Yeah, sorry.
Hi, everyone. I'm Avneet Gariel, also in the Public Health Governance team at Birmingham City Council.
So today we both will be discussing how we've used data from the 2021 census to understand both the entire population of Birmingham, but also specifically the LGBTQ plus population, how it's changed and how it might continue to change, and what this might mean for health and wellbeing in the future. Also, I thought I'd just get this out of the way quickly. Neither of us are the Director of Public Health. We are the governance team. So hopefully that doesn't disappoint anyone, but I will come to explain what the Director of Public Health Annual Report actually is. So hopefully that won't cause any issues. Next slide, please, Avneet. So we've got some really quick housekeeping, which I'm sure everyone will be very familiar with. So we are recording today's session. It will be available on the Healthy Brum YouTube channel shortly afterwards, along with all of the other webinars from this month's conference, if you are keen to look at any of the others and understand some of the insights from them. If anyone does have a question, either you can put it into the chat, or we've got a dedicated section for questions at the end. So if you could just raise your hands when you come to that, and then we can just answer them in sequence. If everyone would be able to keep their cameras and microphones off just while we're presenting the webinar, that would be great. And then when we do get to questions, we can turn them on, or we can go from there. There will be an event survey link that will get posted into the chat. We've also got a QR code at the end as well that you can use if you want to access it quickly. And also we just advise, because we'll be sharing visuals today, that you have the gallery at the side, not the top, just so you've got the sort of the best viewing experience. Next slide then, please, Avneet. And this is just to reiterate the values of the approach of safe places, which is across the entirety of this conference. I'm not going to go through every single point on here. I think I'll just simply state that the values we're expecting of both ourselves as hosts and all attendees are respect, empathy, care, support, and inclusion. Okay, that's great. On to the next slide then, please, Avneet. So what we're going to be covering in today's webinar. So there'll be a quick and brief, hopefully, explainer of what the Director of Public Health report actually is, some context into how sexual orientation and gender identity have been recorded previously, what the census data is actually telling us, what this might then mean for health and wellbeing in the city, including an understanding of an intersectional approach to health issues. And then finally, some of the themes that have emerged from our exploration and reflections from our stakeholders, which we'll come on to as well. Next slide, please, Avneet. So a question I'm sure many people are potentially wondering: what is the Director of Public Health Annual Report? So it's a statutory report that at its most basic can simply just be a report on the health of a local community from the Director of Public Health. In Birmingham, in more recent years, we've chosen to focus on more specific topics, and you can see a selection of them there through those links. And they are produced over multiple stages within an annual basis. So you can see, obviously, the list and the ones that we've produced previously. I should note as well that these slides will be shared afterwards, so that any of the links you see, you will be able to access when you have the slide deck available. Next slide then, please, Avneet. So this year's report, we have focused on an exploration of the 2021 census and what it tells us about Birmingham's population. So the key focus then is on demographic change. And demographic change is a really crucial subject for us to be considering from a health and wellbeing perspective, because there have been a lot of significant changes for Birmingham, both just in the last 10 years up to the previous census in 2011, but also wider trends as well. And what we can start to establish is what things potentially might look like in the future and what the implications on health and wellbeing might be there. So to do this, we split the report into 6 chapters. The chapter, obviously, the very pertinent one that we will be discussing today, will be the one on sexual orientation and gender identity. Next slide, please, Abney. So the 2021 census is actually the first time that any questions on sexual orientation and gender identity were asked in a census. So there's no previous data on a census level, at least. So that's the sort of entire population scale for us to use and compare to. Now, there have been estimates produced both locally and nationally by the Office of National Statistics, which is the agency responsible for the production and delivery of the census. However, they themselves are very keen to caveat that, especially the ones that they've produced locally about a decade ago now, they're very experimental, and so not really to be used for anything that involves actual decision or policy making, but more to see what their model would create in terms of the statistics using that 3 years worth of survey data. So if anyone is curious, you can use that link when the slides are shared and you can have a look. But again, I think the thing to immediately caveat is that these are not necessarily accurate numbers. So that's all that we potentially might have had to use previous to 2021 when it comes to understanding what the population in terms of sexual orientation would be like in Birmingham. Next slide, please, Avni. So in terms of gender identity, it's even more sparse, including on a national level. So there have been some tentative attempts quite a long time ago now by the Office for National Statistics to scope out, potentially say, what the trans population might look like in terms of a figure. However, their trans data position paper, which is from 2009, which I think we could all argue is very out of date now, means that these numbers are also quite inaccurate. So all in all, what does this mean? It basically means that we didn't have much previous accurate data to go on, certainly on a local level, in terms of understanding the population by sexual orientation or by gender identity. So this will reinforce that despite some of the limitations of the 2021 census, which we'll come on to discuss, this data is actually incredibly valuable. And I'm hopefully not editorializing by saying it's basically unparalleled when it comes to a representation of aspects of identity within the population. So next slide, please. Okay, so enough of me sort of warming up as to what we're actually discussing. This is now to look at some of the actual data. So very quickly though, we're just going to go through some terminology because some of the way that the ONS use terminology is slightly different to how we would conceptualize it otherwise. So the umbrella term LGBTQ+, that is inclusive of all sexual orientations and gender identities that are non-heterosexual and non-cisgender. So that's what we kind of use, and I'm sure many people use as the umbrella term to refer to that whole population. So when we come on to discuss how the ONS have presented their data, we've got to break it by sexual orientation and gender identity because they've gone through those two categories. So if you see LGB+, that's referring just to non-heterosexual sexual orientations. So lesbian, gay, bisexual, and then all other sexual orientations. Just also to include as well, if you see all other sexual orientations, that is inclusive of those such as pansexual, asexual, queer, and any others. So this is just how the ONS have categorized this. And then you will also see the term trans plus. This is used to refer to anyone who identifies with a gender identity that is different from their sex registered at birth. And then finally as well, you may also see 16+. So this is referring to the fact that within the census, only those who are aged 16 and above on the day of the census, which I believe was the 21st of March 2021, but I might be wrong. It was definitely March. They were the only ones who were asked. Anyone under that was not asked. So this is only ever going to be talking about the population age 16 and above. Right, hopefully that was all made sense. Next slide then, please, Avni. So this chart gives you a percentage breakdown of how respondents aged 16 and over answered the question on sexual orientation in Birmingham and England for a comparison. So the dark purple on the left there, that's the proportion of those who didn't answer. And we'll come on to that in a bit as well. The blue in the middle is anyone who answered straight or heterosexual. And then the collection of colours on the right-hand side there are all those who identified with an LGBT plus sexual orientation. So I think a really quick headline just to draw out from this is that compared to England, Birmingham has got slightly fewer people who identified as straight or heterosexual, but then a greater number of people who chose not to answer the question on sexual orientation. But what we're going to do now is we're going to take that sliver on the right and we're going to show how those breakdown, the breakdown by percentages within the actual LGBT plus population. If you go to the next slide, please, Avni. So this is how it breaks down for the population in Birmingham. So you can see there that gay, lesbian and bisexual take up about 87% of all those who identify within an LGBT plus orientation within the city. And we'll come on to potentially sort of how the question might direct someone to when it comes to these answers. What we can also do, which is really useful from the 2021 census, sorry, next slide, please, Avni, is create multivariate data. So this is two variables and you can compare, and it's a really excellent way of understanding the population much further than just what you can see on a headline level. So what we've got here is sexual orientation, excluding those who identify as straight or heterosexual and didn't answer the question. So this is only really those then who identify with an LGBT plus population by age group. So what that obviously gives you is an understanding of what the age profile is like for the LGBT plus population in Birmingham. And I think the immediate thing to draw off from there is that the age profile is skewed and weighted quite heavily towards younger age groups. In fact, just under a third of all those who identify with an LGBT plus orientation in Birmingham are aged between 16 and 24. So it gives you an understanding of a greater understanding of that population. And then just very quickly to explain how the percentages work on this chart, these are proportions of that particular age group. So on the left-hand side there, you can see, for example, that's just over 5% of everyone aged between 16 and 24 living in Birmingham identify with an LGBT plus orientation. And that's then opposed, if you look on the other side, to about 0.5 with anyone aged 74 and above. Okay, next slide then, please, Avni. So this is a similar breakdown, but now by gender identity as opposed to sexual orientation. And you can see that it follows roughly the same pattern in that we have a slightly smaller number of or percentage of people in Birmingham who are identifying with a gender identity that's the same as their sex registered at birth, but then there's also an increase or a greater number of people who chose not to answer the question. Next slide then, please. So this, again, similarly, this is a breakdown of gender identity in Birmingham, but just by those who said that their gender identity or identified with a gender identity that was different to their sex registered at birth. And again, you can see here that the greatest or the most sort of common answer with just over half was those who said they did have a gender identity that was different from their sex registered at birth, but then did not give a specific identity. And again, I'm going to show you on the next slide potentially why that might have been the most common. So I will come on to non-response, but what I've got here, that's just a quick cutout. Obviously, the census was almost 3 years ago now, so I'm not expecting anyone to have a photographic memory of what the booklet or the website looked like. But these were the questions that were particularly asked on sexual orientation and gender identity. And so this is a good way of understanding how those particular answers have come out. So for the majority of the answers, particularly relating to gender identity, they came from the write-in option, not simply from just being able to tick a box. So obviously that means that there may have been several people who did feel that they wanted to disclose their identity on the question, but then did not choose to write in an option. And so obviously the way that the ONS have then coded that is it just crowds towards the simple reason that some people chose to, some people did not. So this is really useful for understanding then what the output might be from the whole census exercise. So the important thing to understand about these questions as well, unlike a vast amount of the census, is that these were voluntary. And so if you chose not to answer, that in itself actually constituted an answer, which then obviously gives us another set of data that we can use and understand, because this is quite crucial for understanding the population. So really quickly then, Birmingham's non-response rates for the questions on sexual orientation and gender identity were 9.4% and 8.4% respectively. These were on the higher side, as we've seen already, both higher than kind of the overall England rate, but also compared to a lot of comparable urban areas such as Liverpool, Manchester, Bristol, Newcastle. Birmingham did see higher rates of non-response. So we're going to come on to non-response for sexual orientation. And this is broken down by age group as well, because I think this is useful for understanding how some of the drivers behind it, although we're not necessarily going to try to cover those off now. So you can see that non-response was highest in the youngest and oldest age groups for Birmingham. Now, again, I'm not necessarily going to come out with what some of the drivers might be, but I think we can say it in some likelihood that the factors behind it are not going to be identical for these two age groups. And I think that something further that we can take from this is that we need to understand potentially those drivers more greatly, because there is a risk potentially that there has been, say, an underreporting from the census in terms of both the LGBT plus population for sexual orientation and then the trans plus population for gender identity. And obviously that's incredibly important for using the census data to plan service provision. So next slide, please, Avni. So similar here, this is non-response, but for the gender identity question, broken down by age group. The age groups are slightly different just because of the way that the ONS have presented the data to us. So if you do choose to try and use any multivariate data from the ONS on sexual orientation and gender identity, you will have to use pre-made tables as opposed to most other variables where you can create a custom table and then tweak some of the categories within that. So that's why we've got it kind of presented in this way. But I think you can see roughly the same pattern has occurred. So non-response is highest in both the youngest and oldest age groups. It's actually the highest in the younger group there. And again, lots of potential reasons why this might be the case. But I think that the point to take away on non-response in particular is that underreporting part that could influence future decisions. So that really needs to be taken into consideration when we are discussing this data. Going to hand over now to Avni.
Thank you, Alex. Thanks for that explanation. And now we can go into why does this matter? As Birmingham changes, the health needs of the population also change. Changes in the population can impact on service provisions that are needed in the city. The Census 2021 has been essential to knowing what demographic changes have happened. It allows us to project future trends and to have data to work towards reducing health inequalities. Health inequalities are unfair and unavoidable differences in health across the population. These also include how long people are likely to live, the health conditions that they may experience, and the care that is available to the population. Here, some of you may have seen this diagram before, the Dahlgren and Whitehead diagram. It is a widely used model to represent main determinants of population health. Reviewing the diagram, also known as the rainbow model, it places individuals at the centre with various layers of influences on health surrounding them, such as individual lifestyle factors, community influences, living and working conditions, and more general social conditions. In regards to the LGBT+ community, we know through research the community experienced disproportionately worse health outcomes and poor experiences when accessing health services. So overall, the health and wellbeing can deeply be impacted by the broader ranges of the wider life determinants. In terms of just health inequalities, we're aware through research that there are different inequalities that affect the community, but just as an example that we've taken from the ONS, a national survey, show well-reported inequalities between those who identify as straight and heterosexual with the LGBT+ community. The results here show risk behaviours being higher in terms of smoking rates and alcohol consumption and substance misuse being associated with the community. However, understanding these high-risk behaviours are complex for an individual, but research shows us that we can understand and appreciate feelings of experiences of discrimination from wider society, can cause stresses for an individual and can affect the life choices that they choose. We'll come on to intersectionality. Intersectionality, it's a term coined by Kimberly Crenshaw in 1989. The concept of intersectionality describes the ways in which systems of inequality based on gender, race, social class, ethnicity, nationality, sexual orientation, gender identity and religion, mental and physical disability, as well as other forms of identity, come together to create they intersect and create effects of discrimination that overall can shape an individual's experiences and shape life outcomes. Intersectionality is essential to our understanding of gender identity and sexual orientation because they are impacted by wider social categories. So for an example, historically, people who are Black have faced discrimination due to the colour of their skin, and people who are gay similarly have faced discrimination due to their sexual orientation. So people who are Black and gay can face discrimination on two fronts, and that's what intersectionality explains to us. Cousins et al. Highlighted that Black people are underrepresented in research on LGBT experiences, and as a result, the gay Black community can be marginalised and not truly understood in health and care settings. We often think the most obvious or visual characteristic, for example, being Asian or being a woman, are the obvious characteristics, but being gay or lesbian is not always so obvious, and therefore a holistic approach is required when focusing on health and health inequalities. This is why intersectionality is important to highlight how discrimination and inclusion are not always simple factors and can be solved as a single issue. And why is intersectionality important to public health? It's recognising the shift from people's behaviour to identifying and addressing ways of working and create and reinforce inequalities and poor experiences of care and services. It's important to the work we do in public health to map inequalities for more effective direction in policy and service development. And as explained, intersectionality has influenced the current DPH report, as we are looking at these areas: age, ethnicity, migration and disability, that have emerged from the Census 2021 as some of the main changes in Birmingham, and main demographic changes in Birmingham. And as Alex explained before, when we're looking at multivariate data that's available from the ONS, when we took the census data, specifically looking at sexual orientation by ethnicity, it's interesting to note that, except for the white ethnic group, the most common LGBT+ orientation identified as bisexual. Again, seen in the earlier slides, we could see that age structure may have influenced who has answered. However, but when removing the straight and heterosexual not answered, here we can see that the differences in population identifying as LGBT+ by ethnicity. Again, when looking at gender identity and disability, two different intersections, against not disabled and not answered, we can see figures are quite small, and the fact that we're highlighting that in the presentation and in the report can also kind of represent groups and communities that are marginalised, and that is being emphasised in the report. So when we come on to the report itself and the emerging themes, through the research that we have done for the report, the research has led us to looking at encouraging greater reporting on sexual orientation and gender identity at a local level. The DPH report is based on Birmingham, and we want to look at the population of Birmingham. Also highlighting the health inequalities, particularly relating to mental health, substance abuse and risky behaviours, and also as an outcome promote better awareness and understanding of health needs in the LGBT community. Another part of the report is that we have commissioned qualitative research to, again, advocate for that citizens' voice, including citizens from Birmingham. The samples that were included in the report to hear voices from were individuals who'd identified as gay and lesbian, aged over 16 to 54-year-olds, individuals who identified as bisexual, and individuals who identified as transgender, pansexual, asexual and queer. And the rationale for including the citizen voice were 3% of the population identified with LGBT+ orientation. However, when this population is examined by age, it was skewed towards high levels of identification with younger age groups, and similarly with gender identity, approximately 1% identify with a different registered birth sex. However, the greater concentration of respondents are located in the mid-age group range. And we also included quotes, and also from the full report when it's published and will be available, hearing case reports from all the individuals. Just for an example here, we've taken a quote just to share that an individual has shared, "I'm quite outspoken and I have always been who I am, and people have always generally accepted me for who I am, but I do recognise that the time has gone on. The hatred that some people faced has just gone through the roof." And we've shared experiences from people that have been who added to the report in terms of their citizens' voice and being from Birmingham. And what could this look like in the future, Alex? I'll hand over to you.
Thanks, Avni. So I've probably said this quite a few times already in this presentation, but I'm going to caveat anything that we're saying here with the important health warning that it's speculative, and it's discussing a possible future based on the data that we can see at the moment and an understanding of how the trends might develop. So next slide, please, Avni. So we would expect, for example, that younger age groups are likely to continue to identify with an LGBT+ sexual orientation and a trans+ gender identity at a higher level than if you take the population overall. And I can point that there are some very helpful comments from Dr. Justin Varney, the Director of Public Health, who's kindly joined us. If you look in the chat, just pointing towards some alternative or supplementary data regarding research into non-heterosexual identification within younger age groups. And it's not just obviously exclusive to Birmingham or even the UK, it's exclusive across a number of geographies. So we would expect that to happen. But within that, though, we recognise that the 16 to 24 age group could show great changes, as there is more likely to be fluidity regarding sexual orientation and also potentially gender identity within this age group. So that current breakdown just within the 16 to 24 age group that we saw on the age profile, that will not necessarily hold, as if we were to look at, in 30, 40 years time, look back on censuses, that pattern would not necessarily hold. There is a great scope for variation within that. What we would potentially expect, though, is that the percentage of people who say identify with an LGBT plus orientation will flatten as time goes on. What that means is that 5% or about 5% that I pointed out in the age profile, we wouldn't necessarily expect that to decrease. It may fluctuate slightly, but we wouldn't necessarily expect that to dramatically decrease. So we would expect to see that current cohort of people who were aged between 16 to 24 in March 2021 continue, and again, almost be able to plot them through censuses. We would be able to see them continue, and we would expect then that the next cohort younger than them would potentially identify at the same level or more. And so over time, you would see a flattening rather than it being more of a kind of staircase that you see at the current moment. But that's probably just because, again, this is the first time that this has been recorded on a census level. I think from our research, and I'm sure all from wider research and also just from general experience, it is expected that there will be increasing levels of the healthcare need for the LGBTQ plus community in general. As we touched on some of the health inequalities, but we are aware of there being a vast number more. And I'm sure if you're attending some of the other webinars, there'll be more detail provided on those. And then similarly, oh, sorry, Avneet, just back one, sorry. And then finally, I think just to point out, and again, sort of touching on that issue around non-response, that there is an expectation that there will be people who potentially continue to not disclose their sexual orientation and gender identity within the census. And that is despite it being a completely anonymous survey. But what that means then is that, particularly say for those who do identify with an LGBT plus orientation or do identify with a trans plus gender identity, but then choose not to disclose it, they're not being considered or not being reported within the census. So the numbers may potentially always be lower than the actual reality. It's very difficult to say that with any confidence, but I think it's a consideration that does need to be made when we talk about the data and when it gets used for service provision. Next slide then, please, Abney. So to complement all of the chapters within the report and the data and discussion within them, we asked a series of key stakeholders if they could provide their reflection, both on sort of that presentation of the data as is in the census, but also some of the understanding of what the population could look like going forward. So for the chapter on sexual orientation and gender identity, we asked Bradley Yakub, who, if you've been attending other webinars, will be a very familiar name to you, in his role as chair of the LGBTQ plus and Allies Employee Network at Birmingham City Council. And we also asked Mike Morgan, who's chair of the Hayes LGBTQ plus Pride Network, which coordinates across different organisations and networks in the West Midlands. And so we really wanted their insight and their perspective on what the data has told us and what it could mean for the future. So this is just a very quick summary of their reflection. So again, echoing a point that I think has probably been made by myself maybe too many times almost, is that this is the first time that we've had this data collected on this scale. And for Birmingham itself as well, I should say that obviously there are some estimates again Dr. Varney in the chat pointed out that PHE did create some or produce some estimates in 2017 based on GP data. So again, that might be useful as a comparator, but obviously when we come to saying using the census methodology, this is the first time that we've had anything on this level. So we really do need to employ more learning before we can make any kind of really definitive statements. The overall health service provision and health needs for LGBTQ plus people in Birmingham needs to improve. As we've touched on, there are a variety of health inequalities. In more detail, you will find from other webinars, but the key point is that there is definitely a gap and there needs to be improvement. Similarly, we do expect that although if you look at the data, there is actually a slight drop-off potentially in terms of age group when it comes to identifying with trans plus identities. It's still expected that the trans plus population will increase and that health services and wider services will need to take this into account as there is a more specialised need. And this is something that, and this is a point that both Bradley and Mike make, that obviously does not come from the data and does not come from the census, but it's very pertinent, is that there has been a rise in hate crime towards the LGBTQ plus community. And obviously that is a great consideration. You don't get that kind of understanding just from looking at the data and trying to understand the trends. So that's something that must be thought of and considered in terms of that improvement that we've discussed when it comes to reducing health inequalities. And I think somewhat related to that, and it comes out of the whole census as well, is that as a society, as a population of Birmingham, we should be reassuring that every LGBTQ plus person can be safe and be supported to be their authentic self. Next slide, please, Daphne. So if you just go to, sorry, next slide, just very quickly, these are some links. So again, we would recommend if you do want to learn more and understand more about the census data, we would direct you to these. I would particularly recommend, if you're a fan of using interactive tools, the census map tool. It's very intuitive, it's very useful. It really allows you to look at the census data on a granular level for the entirety of England and Wales, but obviously whichever geographic area you are responsible for or you work with, really useful for understanding that. And I'm sure many people on the call probably have already got some familiarity with it. So we've now come to the time when we can open to questions. But what I'm going to do quickly is we're going to leave the slide up, the next slide up, if that's all right, please, Daphne, sorry, that's got these QR codes on. Hopefully they're big enough for you to be able to scan on your screen. So the one on the top there, if you access that one, that will give you an itinerary of all the other events that are happening over the conference this month. And then if you use the one below, you'll be able to complete the evaluation for today's webinar. And I think Dawn has very kindly posted a link to that also in the chat, if that's an easier way for you to access. So we can now take questions. If anyone would like to either raise their hand or put them in the chat, we're happy to do so.
I can see Chris's hand and
yeah, should we go? Well, I think Chris was first. Yeah, Chris.
Thanks. It was a really interesting presentation. Thank you. I just wondered on the non-response rate, within the census data, do we know who's completing the census? Because I wondered if it's not necessarily young people that aren't responding, but it's maybe their parents or their grandparents who are completing the census and aren't responding on their behalf, was one of my thoughts.
Yes, that's a very fair point. So obviously we take into account the within that 16 to 24 age group, potentially also older, but all the censuses are generally filled out by what is called a household reference person, who's sort of the prime completer of the census. So you make a very fair point that a lot of that non-response may come from people who are, again, completing it on behalf of other people and for whatever reason have chosen not to complete the answer. So I think the issue that flags up is that, again, there is an issue around underreporting. And I think the consideration as well, and it's not exclusive to the younger age group, but if we just take that 16 to 24 age group, for example, there's two kind of pertinent things, even as we talk about this right now. As I said, it's almost been 3 years since the census. So there'll be quite a few people within that who potentially may have been, let's say, even say between the sort of 16 to 18, 19, they may have been living at home when the census was done, and now they are living independently, they're at university, they have a sort of different life and a different, they form a part of a different population if we were trying to do the census now. And so the issue there is that how much is this data still valid even 3 years after it's been done? And the other issue obviously is that, as you point out, in that 3 years, there'll be lots of people who have aged into that age group. And obviously we have no kind of, apart from extracting some of the kind of trend that we can see already, we have no understanding of what the sexual orientation kind of profile might be within that current cohort as well. That's one of the limitations with the census, that it only comes out every 10 years. So after a while, you could say it does become quite inaccurate. And I know that the ONS, I think, are planning on potentially bringing in a more dynamic system that, rather than it just being 10-year intervals, gathers data on a more regular basis, so you can actually understand the population at a sort of more accurate within time. I hope that answered that. Sorry, I feel like I've went off on a bit of a tangent.
Yeah, thank you.
And just to follow on from what Alex said, surprisingly, we haven't mentioned it, but actually the time the census was taken was quite a peak time during the pandemic as well. So it might not also be a true reflection of where people may have been living or displaced, or when answering the census questions as well. So that would have had an impact, but because it was the first time it was asked, we've got nothing to compare it to as well. And then generally, I think generally there is an understanding that every 10 years there is a culture shift. So we would hope to see more representation from the communities in future censuses.
Was there another hand up?
I can see a hand, Alex, but I can't see the name. Can you see it?
Is it Helen?
Yep. Hi. Just a reflection on the people who preferred not to say. In my experience, that comes from two views, really. In when I've asked people to fill in forms, one is that people don't think they should be asked the question. And then the other one is that even though it's anonymous, if they're in a situation or culture where it's not seen to be approved of, even if it's anonymous, people won't fill it in. So it could be either of those. It'd be interesting. Obviously, it makes us all these things more and more questions to fill in, but it would be interesting because it either means in a group, if you're getting this feedback, you've either got a group of people who don't feel safe to be out, or you've got a group of people who are homophobic. So it's a very different situation. So that's an interesting one.
Yeah, and it's a fair point. I think as you say, the drivers behind them, what you sort of kind of aggregate on behind what the behavior or the motivation might be. I think it's really interesting that you point out the first one being that people have said, or potentially sections of people have said, that it's not a question that should be asked, that these are sort of very private aspects of our identities. And I think that was basically from trying to understand how the ONS developed their methodology, particularly for the sexual orientation question. These conversations were sort of had around the time planning for the 2011 census, but it was deemed essentially that this was not something that could be, or really, should be asked in the same way as what someone's housing status is or what their age is. This is a much more kind of private aspect. I think what has obviously come out of the discussions is that it's really important to understand what the numbers are, and also what the sort of disposition of the LGBTQ plus community is, because it's incredibly important for then planning and understanding where those health inequalities might be coming out. And this is only something that you get through the multivariate data in the census, is understanding exactly all of the different variables that affect the population. Obviously, we've only just presented a really tiny amount today, and obviously, if anyone is interested, would definitely recommend having a look. I can just see also, I think Justin just put a very apt comment into the chat as well around consumer acceptability for the question, which I think is an interesting consideration when it comes to this. And it might be that, again, in future censuses, we may see more variation. We may see more things answered that we're not necessarily going to feel happy as a majority to disclose now, but we also might see within, say, particularly the questions on sexual orientation and gender identity, we might see a greater or a more broader suite of options when it comes to answering. Right. I think sorry.
I was just going to say, just to follow up on that as well, and that is when we're looking at the census, we're working with numbers. We're not exactly working with the voices, and that's the rationale for including citizen voices in the DPH report, with like the full case studies that will be included, and having those voices shared in the report. It does kind of share the experiences of that trust. Even though the census is anonymous, there is still that trust factor that potentially can be a driver for people not responding or unable to report. And I think it's important to just the consideration that has been discussed already, that the underreporting are contributed by factors that we might not necessarily be able to write down on paper, black and white, but we are aware that they exist.
I think there are two questions in the chat. If there are no more hands, one is from Osh, which is, which strategies / forward plans will this data be feeding into, if any? So this census data obviously exists exclusive to kind of our exploration of it on the DPH report. But what we would hope is that we're in a stage now where we're very close to publication. We're just achieving sign off on it. And one of the main areas it will be published and signed off by is the Health and Wellbeing Board in Birmingham, which obviously is a partnership organisation including lots of key organisations. So what that will mean is hopefully that there will be a chance for all organisations to look at the report if they have the opportunity and to understand the insights that we've particularly decided to select from it. Because the issue obviously is that the census is a massive data set. And when you start to add in multivariate aspects to it, you're timesing it by itself. So you can just get lost in it. So obviously you do want to go in and you want to understand those particular aspects relating to the work or the strategy or the plan, as you've said, that you're then going to need as your evidence base. So the hope is that what we would be able to do post-publication with the report is be able to say to those who maybe want to use any aspects of it for planning or for strategies, here is a presentation of the data that you can use as an evidence base. The census, all the census data does still exist and is very accessible. So we would 100% encourage drawing upon that. But in terms of our presentation of some of the particular aspects of multivariate data, that could be used in particular. So we've sort of, I'm not a huge fan of the term, but unfortunately I'm going to use it. We've got a bit of a socialization period after we publish the report, where hopefully that means that it can get taken up. And then there was just a question from Justin as well. Does the census data allow us to look at sub-Birmingham level distribution of the LGBT+ population? One would suspect a higher proportion in areas with high student populations. So yes, if you use the interactive ONS census maps tool, that's really useful for this. It does only obviously let you look at it on geography based on one variable. So if you just selected say the sexual orientation variable, and then you just wanted to look at where the greatest geographic population of those who identified as bisexual is, you can do that. Now, some aspects, it won't necessarily allow you to go all the way to the most granular level, which is something called an output area. I'm not going to go into that because that's very technical for the ONS. But because there are sometimes small number suppression, you can only access it at certain levels. But certainly, if you were to use that tool and you were to look at, okay, where are the kind of greatest geographic dispositions of those who identify as bisexual, it's really interesting to understand. And yes, you would definitely find the greatest concentration around the Selly Oak area near the university, Birmingham University, I should say, and then a lot around quite the real centre of the town or the city as well. Just seeing if there are any other. Yes, so Chris does make a good point in the chat as well. So as we said, there is sort of I think the household reference person compared to the entire population of the household. And again, this is maybe a limitation to the census that the person completing it obviously has their own attitudes, biases, and that might influence then how the census is completed. So even though it is still one of the most accurate sets of data that we have relating to the whole population for Birmingham, particularly relating to the LGBT plus population, it means that there may be some discrepancies within that. I think that's everything in the chat. I don't know if anyone else has any other questions they wanted to ask. Sorry, Avni, did you want to come in on any of that? Sorry.
No, that's fine. Thank you, Alex.
Okay, I think that's everything then. So thank you very much for being able to join us. We hope that the webinar was useful, and I'm aware that we've probably skated over quite a lot of data. So I would recommend both potentially being able to read the report when it gets published, which will be next month, but also just when the slides are available to use some of those links to understand the census data better, and also just relating to some of the myriad of ways that the ONS have developed the methodology for asking these particular questions, because it's very fine-tuned to make sure that the answers that have been produced are as accurate as can be. And obviously, as we've said multiple times as well, this is incredibly important for understanding the LGBTQ plus population in Birmingham and what that could look like in the future, and what the health needs of the population will be. So thank you very much, everyone.